Dear attendees, like we call upon our next presenter, Dr. Elizabeth. She is going to present on the perceived quality of life among diabetic patients attending the outpatient department at a district hospital in South Africa.
Good evening, everyone. My presentation is the perceived quality of life among diabetic patients at the district hospital in South Africa. I'm Dr. Elizabeth Reji. Summary of the presentation is introduction. What is the problem identified? The aim of the study, the methodology, the result, and conclusion. We can go to the next, So from the literature review and the introduction, diabetes is a non-communicable disease that has become a public health challenge. 422 million people are living with diabetes in this world. 321 deaths have occurred in Africa. There's an increase of diabetes from 14.2 million to 34.2 million by 240. South Africa has the highest prevalence of this disease in the sub-Saharan Africa. The primary goal of diabetes mellitus is to improve the quality of life through early detection or diagnosis and treatment. This is the tool that we use for this survey, so I thought I needed to explain this in detail. This is a tool that is used to look at the health status, and it has 36 questions measuring 8 scales of health. It looks at the social functioning, the vitality, the role limitation due to emotional problems, mental health, physical functioning, limitation due to physical problems, body pain, and general health perception. And there is one question asking about them if they had any problems during the past year. It has been proven that this can be used, this health survey can be used in both general and specific population in comparison, and you can also use it relative diseases. I used this instrument because there's high internal consistency and reliability for all the scales in the questionnaire. The compact alpha was 0.76 to 0.86, and it was used in diabetic patients in different countries. It has high sensitivity, it has high construct validity, and is sensitive to changes. And it is used in different countries, and it can be translated into different languages. In South Africa, we have English and Afrikaans, and it was also converted to English and Afrikaans. So since there was no study in South Africa on using this questionnaire, we decided to use it and to find out what is going to happen. Problems. Although the quality of life of patients is not a new concept, there is a paucity of local information among diabetes in South Africa on health-related quality of life. American and Australian studies have shown that a mean score of quality of life was low, which is 43 and 48.6 on the physical component summary. In South Africa, a study done in Pretoria has shown that widows have significant poor quality of life than married or single respondents, and the p-value was less than 0.01. The married and divorced subjects have significant worse quality of life when compared to their single compartments. That was also shown in UK. The aim of the study was to assess the influence of socio-demographic factors with the perceived quality of life among diabetes attending an outpatient department in a district hospital in Gauteng province, South Africa. Next slide, please. Methodology. A cross-sectional study was undertaken on 270 diabetic patients over a period of 3 months in a public district hospital in 2016. There is a figure that is showing we approached 307 people, 17 declined, 290 people were ready and willing to participate, but 20 people were excluded, so we had 270. The exclusion was diabetes in pregnancy, too ill to participate, or they participated in a pilot study, or their duration of diabetes was less than 1 year. A researcher-administered questionnaire using a modified version of the short form 36 tool was used to collect the data. Data was analyzed using descriptive stats and logistic regression. Ethical grant was granted from Witwatersrand University, and I've put the number there. Next slide, please. Okay, this is showing the result. You can see that this figure is showing high quality and low quality in each component. The mental health component is the first one that you can see on top, and then it's physical component summary. So those are summarizing the individual ones, which you can see on the other side. You can see that physical functioning and social functioning had high quality, and which increased the physical component summary. Next slide, please. Regression analysis. Here you can see that if a person is about 60 years and is married, they actually have good quality of life compared to a person who is a widow. And primary education did not show much, where it was actually showing low quality of life in this diabetic patients, including widows also. They had low quality of life. If your diabetes was less than 5 years and you had no comorbid diseases, you were more able, you had better quality of life compared to the people who had comorbidities and who had more duration of diabetes. Next slide, please. The hypothesis of this study was that there was low quality of life due to social factors among diabetic patients attending the district hospital. So with this study, we could prove that the quality of life was low, and it also affected the socio-demographic features in South Africa has also affected the study, which was similar to the Australian and American study. Next slide, please. These were my references. Next, conclusion. Poor quality of life among diabetic patients was seen in this study. Marital status, education, employment, income, comorbidity, and the onset of diabetes had an impact on the quality of life. So you see the social demographic factors had an impact on the diabetic patients. So when we consider to see these patients, we must consider symptom stresses, functional status, emotional or mental well-being, and multiple chronic diseases during our clinical assessment of our diabetic patients. And we must be holistic in managing this person rather than just treating the patient. Then further studies, because reading other literatures, we could see that further studies have shown the effect of depression, religion has an impact on the quality of life. And that ends my study. Thanks so much.
Thank you, Ms. Elizabeth. That was a great presentation.
Thanks.
Now I request the participant to raise the questions to Ms. Elizabeth so she can answer. You can raise it either in the Q&A session or in the chat box. Ms. Elizabeth, we have a question from one of our participants. The question is, why is that diabetic disease prevalence is the highest in South Africa when compared to other South African regions?
I think that I'm not sure, but I think that we are actually having more obesity among the youngsters and also the people, working people, because we are becoming more, more westernized than what is happening in the other African countries.
There's another question for you, Ms. Elizabeth. So what would you take on a relation between keto diets and diabetes B?
Can you repeat the question, please?
Yes, sure. What would you take on the relation between keto diets and diabetes? I guess that's one of the.
I do not.
That's the one of the diet plans, I guess. Keto diet.
Keto diet.
Yes.
Oh, okay.
K-E-T-O, keto.
I am not sure because this study was not related to that and I have not read anything around that.
Thank you. Any other questions, participants? Yes. So another question is, what diet is best for diabetic patients?
A balanced diet is better for diabetic patients. You should have more vegetables. It's like a plate where you have starch, a quarter of a starch, then vegetables, and also you should also have fruits along with it. It's not only about diet. Diet is not the only reason that you get diabetes. You also need to exercise, have a better modified lifestyle, because nowadays most of us are stressed and working under stress. So we need to find time to have exercise to reduce our stress level, because if you have more stress, it can increase your chances to become diabetic.
The next question is like, is nutrition a critical factor in the HGH incidence of DM in SA?
Nutrition, clinical. Okay, remember, nutrition is also a factor because my patient is a poorer community and they have less than $50 or less than $50 earnings per month. So they are not able to afford a balanced diet. So they actually eat more starch than what is required for a diabetic patient. So nutrition is very important in a diabetic patient.
There's one more question. How much emphasis has been put on to health education and promotion about the risk factors of M in South Africa?
Okay. All the health, the nurses and the doctors that are working in the hospitals, they do give education, health education to the patients, and also the dietitians do give. Nowadays, we have community health workers, which is equal to the Anganwadi workers in India, that they go into the streets and houses and also teach them on diabetes. But they have just started recently, it's less than 5 years. We are yet to see if there's a change because of that. But if we do not have, if poverty is still existing, diabetes will still increase. Because it's not, we need to give health education and see they have adequate food and nutrition and get better salary to buy all this, or income to buy all this food and do exercises. So health education alone and health promotion, I don't think that is the only way we should do. We need to see this in a holistic manner and see that the social aspect or the economic aspect is also improved among the people.
Thank you so much, Ms. Elizabeth. That was a wonderful presentation.